make sure that everybody knows that Scott does an enormous amount of work every year to put these protocols together, that he's the keeper of the protocols for both counties. And I don't know what we're going to do when Scott isn't here to do them for us.
I don't know if that's good or bad, because that means all the typos are something they're going to come after me for. So, but
No.
Anyway, but welcome and thanks for that. When the last couple of times we talked about your cat. How's your cat?
Actually, my cat is doing pretty well at the moment. For those of you who don't remember, I have a cat who has diabetes and a bunch of other medical problems, had a gallstone that had to be removed, has this chronic ear infection. And currently, he gets his insulin. He is pretty happy with that. He comes to the food and likes his food, so he likes his insulin.
Oh.
He's also on chronic pain medicine. He's actually taking opioids for his chronic pancreatic pain. And he doesn't like that because he doesn't like the taste. He doesn't mind getting stuck with the insulin syringe needle, but he doesn't like the taste of the opioid.
You have intranasal Narcan for him. So.
And I haven't figured out his morphine equivalents either.
Perfect. So, okay. So actually, we're going to talk about pain control. So we're going to talk a little bit about ketamine. It's been in one of our protocols. It's being added to another. So let's talk a little bit about it. Just kind of refresh kind of what ketamine is and
yeah, exactly. So speaking of pain,
yeah.
We know that opioids are a pretty good pain medicine and they work rather well, but they have some downsides. And I'm sure that there's not anybody who's listening to these videos who hasn't seen something on the news or read something in the newspaper about all the concerns about the overuse of opioids and the, quote, epidemic of deaths. And we certainly don't want to contribute to that.
Right.
So it's not that we don't want to use it, but we want to do everything in addition that we can. And one of the things that is an opportunity here is to use ketamine as an adjunct to add to opioids when we've kind of begun to maximize out those doses.
Right.
I do warn people that this is a fairly new thing. And so the emergency departments may go, you did what?
That's right, because I think not every emergency department is, well, the physicians there are giving it, I don't think. So.
Right, so as you might remember, I do palliative care. And so I have had, I'm one of the 3 groups of physicians at OHSU actually can use it: anesthesiologists, palliative care physicians, and pain specialists. So the ED docs, even at OHSU, for example,
won't.
But they're enthusiastic about us using it. And we are telling all the hospitals before we come. That doesn't mean they'll remember when we actually get there. So
a reminder, let them know if you've given it when you get there. So it was developed a long time ago?
Yeah, so it started out in the 60s as an animal tranquilizer, particularly actually for horses. And then it was a drug called PCP. You maybe remember people getting high on the PCP and becoming quite agitated. Ketamine is not exactly the same drug, but it's related. And it's unique in its mechanism. It's not a sedative per se. It is a good analgesic, a good pain medicine. But what it really does is essentially dissociate your higher cortical functions from the rest of your body. And so it's an all or none phenomena for the dissociation. It's not that as you give more and more of it, they get more and more sedated. It's once they dissociate, they are dissociated.
They're dissociated. Okay. So in our protocols, we're adding it for basically acute pain, and it's been in there as an induction agent for RSI, so we'll talk about that a little bit.
Yeah, so maybe you can comment a little bit on that, Scott. How much have you been using it for RSI?
So I don't think at least our agency hasn't used it for RSI. I don't know if the Clackamas agencies or the other Washington County agencies have in the past. I don't know if, I think Multnomah County has, but I'm not sure exactly how much it's been out there. In the past, it was if you didn't have etomidate, that was the kind of the go-to medication. So I think it's if you have etomidate, at least for some agencies, that's going to be the kind of the standby. But there are some advantages to it.
Right, and we'll talk about that in a minute. But yeah, in Clackamas County, it has been used some when we were out of etomidate. And I think I remember that now. You guys never actually ran out.
No.
You got towards it.
Yeah, we have our dealers. We were good. We found them. So.
Do they do the ketamine and PCP too? Those same dealers?
No, different dealers. So anyway,
moving right along.
So ketamine's got a lot of advantages. So
yeah, in some ways, when I read this and I say that the hospitals are reluctant to let physicians use it, you wonder why. It might be the perfect agent for pain. And we're using much, much lower doses than for induction. It is like a 10-fold lower dose, and that's an important thing to keep in mind. But unlike any other induction agent, it actually is a good pain reliever, and it's an analgesic, not just a sedative. It potentiates the opioids, so they work together. It prevents something called opioid hyperanalgesia, which is an issue for people who are chronically taking it and not very much of an EMS thing, but that's another advantage. And it doesn't cause respiratory or cardiac depression. So it's really a good drug in some ways.
Okay.
And this is just a study proving that. So they took a group of patients who had been in the hospital having a surgical procedure and gave them ketamine in addition to their opioid, and actually found that they needed like 30 to 50% less of the opioid.
That's good. Tell us about how it works as far as mode of action.
So this picture, I think, is important. And it's important because if you are dissociating somebody, say you're doing it for induction, this should not be happening for the pain patient.
For pain patient, yes.
This is what my brain is not connected to my body looks like. And I tell you that patients' families will be a little freaked out if they happen to see it and you don't warn them. So that's one of the things I'll say. I use it a lot for procedural sedation in the ED.
Okay.
And I'll say to mom, you know, they're going to look funny.
Heads up, they're going to look a little bit
And it's
crazy.
this thing called an MWA receptor that is what it works on. And I bet there's not very many people out there who could care what the name of the receptor was. But
So the dosing, so IV, onset 30 to 90 seconds, in duration 5 to 10 minutes. IM is going to last a little bit longer. Onset's 3 to 4 minutes, and duration 12 to 25 minutes. So.
yeah, so it's quick on, which is good.
Yeah. So lots of different routes, but our protocols are really going to be giving it by IV. Again, you're going to need one if you're going to give the RSI medications or pain control.
Yeah, the rest of them are just for awareness, and
Yeah.
maybe some odd situation might come up. I can imagine a number of odd situations. But
Yeah. Okay, so analgesic dose, you want to talk about that?
yeah, so this is the dose for the person who is getting it for pain relief. And this is the sort of general dosing, but for our protocol, which we'll see in a moment, it comes out to 15 milligrams is the dose that we're going to use.
Okay, so, and then this is going to be also after you've either gone through 200 fentanyl or 20 of morphine. And at that point, after you've done that, if the patient's still needing pain control that you don't think you can achieve with fentanyl or morphine, then you can go ahead and move to ketamine. Is that correct?
Correct.
Yeah. So, and then again, 15 milligrams IV, and you can repeat once at 30 minutes. And I think unless you have a long transport, most folks are going to
Yeah,
be.
I think that
at the
that's
ED by that time.
unlikely, but
Yeah.
we just want to make sure that, again, there's some very deep areas of both Washington
Yep.
and Clackamas County that it comes up and happens.
That you might, yeah, get to that.
And the other thing is that is a very small dose. You're going to have a big bottle,
Right.
and you're going to take a tiny amount out of that bottle, and you're going to go, gosh, I didn't take enough. I must have miscalculated it. It's a TB syringe or an insulin syringe, and it's going to be, depending on the concentration, but the most likely one, it's going to be like 0.3 cc's.
So, real small. And then again, for the RSI, the induction dose, just a reminder.
And again, this, as you can see, is much, much higher. It's 2 milligrams per kilogram. This is unchanged
Yeah.
from the old one.
So again, that's still in the protocols as it is. So some contraindications, good to talk about.
There's some evidence that it increases intracranial pressure. There's some doubt about that, but we're going to not use it in this indication for that. And then the one to pay a little attention if you're going to use it for an induction dose is if somebody, say, had a ruptured globe or a major injury to the eye, because it can increase intraocular pressure. Severe uncontrolled hypertension or flagrantly psychotic people are
That's what we're gonna use it.
contraindications.
So, and all these are the same, nothing's changed as far as the contraindications. So ketamine, we're just kind of reminding you of what's out there. So, and then there's a thing with emergency reactions. So why don't we
Right,
talk
so
about
the
that?
thing that made people have some reluctance to use it as an induction agent and as a procedural sedation agent was that some people woke up agitated and with these vivid, very frightening dreams. It turns out that we can control those dreams. And it really makes a difference what you say and do when you give the medication. So I'm going to give this medication to you, Scott. I'm going to give you some medication that is going to make you have very, very vivid dreams. That's normal. They're bright. They're quite remarkable. Lay back, relax, and enjoy them.
Okay.
And as you go to sleep, think about something you want to dream about. And this works, actually telling people these things. My example is I gave it to a kid one time who loved motocross. And when he woke up from the dream after I gave him ketamine, he was going, vroom, vroom, vroom. So people
So
really,
it really does. So think about that before you give it to as well. So It generally, again, occurs at higher doses.
Right. So
Yeah.
again, it is very, very unlikely at the doses we're using
For
for
pain control.
pain. It's more the emergence after intubation, but of course we're going to sedate them and we get to miss it and leave that for the hospital.
Right. So, good. So, side effect, laryngospasm?
Well, so this is the scary one. Well, first of all, again, at the doses we're talking about in terms of pain, it is very, very rare. And the one thing that you do know is you need to give it fairly slowly, because the likelihood of laryngospasm is pushing it.
Okay.
And that's more of an issue, again, at the RSI dose. It's hard to give 0.3 cc slowly.
Right.
And then, although it is very scary, usually just by bagging the patient, you relieve it.
Okay.
And if that doesn't, and you're doing an induction, you're going to paralyze those
Paralyze
cords
it
in a minute anyway.
Yeah. So, again, none of this is new. We're just kind of refreshing kind of what's in the protocol currently. Nystagmus?
Yeah, so this is just a good trick. If you're giving pain doses and you're worried you might be getting to the point that you're going to dissociate, you get nystagmus before you dissociate.
Oh, okay.
So if you just check their eyes and they're not twitching,
That's a good indication.
that's helpful to know that you're okay.
Okay, so behavioral health. We have a brand new protocol. So let's talk about that a little bit.
So why do we have a brand new protocol,
That's
Scott?
my question for you. Why do we need a brand new protocol?
Well, as I think almost everybody has heard, there's this new thing that is being created in Multnomah County called Unity Behavioral Health Center. And it's a consolidation of hospital beds. And the reason it's important is they do not have a emergency department associated with them. And some patients can go directly to Unity without going to an emergency department if they have only a mental health problem. And the protocol defines that. In Clackamas and Washington counties, we honestly don't know how frequent that is going to be, because we still will take patients where they request.
Right.
But on the whole, particularly in Washington County, most patients are used to going to St. Vincent's. They're going to continue to go to St. Vincent's. That's not going to change.
Right.
But patients, once they've gone there, they may like it and then request it.
Yeah.
And in Clackamas County, the police are going to definitely send some of their patients there. In Washington County, so far the police have said they're not.
Okay. That's good to know too. So, and it's opening.
No, January 9th.
So coming up
basically
pretty quick.
the same date that we picked to start the new protocols.
Okay. So since it's opening, we should probably talk about who's going to be able to go there.
So both voluntary patients and patients who are on psychiatric holds can go to Unity. They have a inpatient pediatric unit, but they don't want pediatric patients in their ED part of Unity. So it's ages 18 to 65. They also don't have a geriatric facility. And the geriatric patients are much more likely to have other medical problems.
Right.
And then it's basically a mental health complaint without acute medical condition. And if you go back to your protocol and read it at some point, there's some more definitions of that and what it's defined as. But just in general, it's mental health without medical.
Right.
And we've sort of described it as you can walk, you can talk, and eat a sandwich.
Just kind of
I don't know if you have to do all three
Three
at
at a
once or 2 out of 3.
I think it's all 3. So if you can do that, then I think that's a candidate for the Unity Center. So, so who can't go there? Again, it's going to be really anybody that's kind of got questionable health going on.
Right. So, but some specific ones is if you think it's an overdose,
right.
Intoxication that impairs walking, talking, and eating. Just being a little drunk, they're okay with. It's just if they're truly impaired by their alcohol.
Okay. So they will take intoxicated patients, just not at the level where it really impairs them.
Correct.
Okay. So
And then those who require chemical restraint. And we're going to talk in a minute about a new drug, which is not chemical restraint.
okay.
And then severe withdrawal. And here's some things just that I put in here as red flags that if you see these, this likely is not a primary psychiatric issue. People with changing mental status that kind of come in and out of wakefulness, that's delirium or something else, but it's not primary psychiatric. Psychiatric problems don't give you abnormal vital signs typically. If their pupils are dilated or constricted, that might be a sign of an intracranial injury. It might be a sign of a drug intoxication, but again, it's not typical of mental health.
Okay.
And what I suggest to people is, if your patient's pupils are more or less the same size as your partner's, we're doing okay.
Okay.
If they're bigger or littler, that would be a sign.
There you go.
And then a brand new psychiatric illness after the age of 30 is very rare. And so think drugs there.
Okay.
And also, it doesn't tend to happen over hours to days. Psychiatric illnesses progress more slowly.
And all this is in the protocol too,
Yes.
so be sure you take time to read through this as well. So with this, we have a new drug that's going to be appearing to help us a little bit. So let's talk about olanzapine.
And olanzapine is not only for patients going to Unity. It's for any mental health patient that you think would be better served by being a little more relaxed and quiet in the back of your ambulance as you're transporting them.
Okay.
It is not related to a benzodiazepine. It's related to the psychiatric drugs like Haldol, Geodon. And it's an ODT like our ondansetron, so it's very easy to give. You don't have to have water. They can just melt it in their mouth.
Okay.
And you might actually avoid chemical restraint. And
Yeah.
not only may they still go to Unity, it was Unity's idea that we start carrying this.
Okay. So we're going to kind of work through just a little bit of the updates to the other protocols now. So airway management.
So first of all, what we discovered, somebody, not him, created two different protocols, one for airway management, one for airway with intubation,
Right.
with induction agents. And it didn't make a lot of sense. So they're combined, but there's really very few changes in them.
Right. So basically the intubation without paralytics, the intubation with paralytics is now basically one protocol. So let's just talk about the few things that have changed in here. So again, we talked about clarification for atominator ketamine. Clarifies that if the person has a painful condition, you can treat it. And it adds a few other things to videolaryngoscopes are coming, at least in Clackamas County and some other agencies as well. So there's just some language in there that talks about that. PEEP valves, some of the agencies are going to be adding PEEP valves.
And some of them are going to be entering the pressure control
bags. So you might see
so there's some new toys out there.
So just some language in the protocol that talks about that. When we go back and talk a little bit about the pain, so there actually now is as well language in there that allows you to treat pain post-intubation. So if you think the patient is in some pain from the procedure or whatever else, you can treat them per the pain management
Or they had a
protocol.
broken femur before
Yeah.
you started the induction or whatever.
Whatever it is, yeah. So you can still go back and
So
treat that.
again,
as
it's not a requirement because
Nope.
it's agency and situation dependent, but it makes another thing available to
Yeah.
make your patient comfortable.
Absolutely. So new protocol again, orogastric tube insertion. This is nothing new. Everybody's had this available to them. We just kind of memorialized it in a protocol. Orogastric versus nasogastric. Remember if there was a reason for that?
Because it's just harder to pass through the nose.
Then we go through the mouth. So
And again, so this protocol is nothing new. In fact, it's a procedure page. Some agencies felt like if you didn't have a procedure page for it, you didn't have a authorization to use it, and felt a need to have a page. And you can read the page if you want to, but I think this is a training issue and is pretty much covered. The indication is to alleviate gastric distension, reduce aspiration, and to make it easier to ventilate the patient. And then you can see the contraindications there. Basically, a damaged esophagus is what it comes down to.
right. So again, it's something we've had in our arsenal before. Go ahead and look at the protocol. Read through it, and again, think about using this in these patients, especially your pediatric patients too. Again, that you have intubated because they tend to get a little bit more distended.
And I think we're at the
And
end.
I think that's it. So any other things you want to cover? Or I think we're done for the year. So
Yeah, this is going to be a little bit of a challenge, I think, this year in terms of there aren't huge substantive changes, but there are lots of little changes.
Yeah. So please take time to go through the list of changes that gets sent out by your agency's training staff. Look through the protocols, and if you have any questions, go ahead and contact them, and they should be able to help you out. So Dr. Schmidt, thank you for coming in.
Thank you, Scott.
Have a good day.